We'll get started. Let me share the screen. So today we're going to be talking about EENT in terms of urgent care. Does anyone know what EENT stands for?
Eyes, ears, nose, throat.
Yes, good job, Amanda. Yeah, eyes, ears, nose, throat. So we're going to cover two cases today, and these are probably the most common complaints you'll be dealing with in an urgent care setting for EENT. So that way you'll have some familiarity with these conditions moving forward. So the first case we're going to cover is case 15. It's titled Ear Pain and Inflamed Conjunctiva. So we'll watch the video. Volume should be good.
We have here today a very nice 4-year-old who, for the last days, had a fever pretty high up there, 103. And I think you told your mom your ear hurt. Which ear hurt? Can you point to it? That one? Thank you. And I heard your cheek hurts. Where does your cheek hurt? Right there. This has all come on the last day with ear pain a little bit before it and cheek pain and a little bit of snot. And then also his eyes have become quite goopy and inflamed. And we'll just kind of show here we've got a lot of discharge and conjunctival inflammation, scleral injection going along with that. And it really is both eyes, but a little bit worse over here towards the left. You can see that the cheek is also rather inflamed appearing, but not down as far as the angle of the mandible over here. And thank you very much. You're very helpful. Say bye-bye.
Kid's like, I'm not saying bye-bye. Can someone summarize the video for us?
Basically the child was complaining about pain on his right ear and his left cheek.
Yeah.
And his eye seems a little swollen and is having a lot of discharge also. And he had a really high fever for a couple of days.
Perfect. You hit everything. Good job. So yeah, we got this 4-year-old who's dealing with a fever, maximum temperature of 103, and then the right ear pain, the left cheek pain. He's got a lot of snot. So it sounds like he's got a lot of things going on. So before we continue, I want to just talk about eye anatomy because they mentioned some terms in the video. So I just want to clarify that. So the eye, the two parts of the eye we're going to be mostly talking about are the conjunctiva and the sclera. So the conjunctiva is basically this thin membrane that forms like the skin of the eye. I know it's kind of gross to think about, but that's like the best way I can describe it. And it covers the majority of the surface of the eye. And it also it covers the underside of the eyelids. So you can see the the conjunctiva labeled here with this hot pink and this blue, and it's going to cover the front part of the eye as well. So it makes up like this just thin membrane. And then the sclera is sometimes confused with that. So the sclera is this continuous structure that goes into the cornea, and it basically forms the wall of the eye and it gives it structure. So that is the actual white part of your eye. It's the sclera. The conjunctiva is just on top of it, like a thin, clear membrane. So in the video, they used this term scleral injection, which was referring to the redness seen on the surface of the eye, and that's because of enlarged, dilated blood vessels. So when someone has bloodshot eyes, that's what it is. It's that scleral injection. So going back to our patient's case, let's look at vitals and demographics. So he's almost 5. They have his weight, and then they have his temperature. They really don't give us any other vitals because of course they wouldn't. So are there any other questions we want to ask this patient? Any other questions we need to ask mom or figure out to better narrow down our diagnosis?
Maybe ask like what has he been doing these past few days or the past week or so, anything like out of the ordinary of some sort, or
Yeah.
where has he been?
Yeah, definitely. What's his daily routine been like? Is he in school? Is he in daycare? Has he been around sick kids? Finding out all that information is definitely super important. Any other questions we want to ask?
Maybe if he has allergies.
Yeah. So sometimes allergies can present with a variety of symptoms. I don't know if anyone here has allergies, but like I get really bad allergies and my nose will either run or to be super clogged, and sometimes I'll get like eye discharge and I just feel in general like a pile of garbage. So it's important to ask that because if he has allergies, then that might be contributing to some of his symptoms, definitely. Any other questions we want to ask? I would maybe ask something like, they talked about how he had a fever. Has he taken any medicine for the fever? That's definitely something I want to know, especially because he has a fever when he's coming into the urgent care. So I would want to medicate this child, and you need to know if they've taken anything, what time did they take it, how much have they taken. Questions like that are always important to ask before you give medicine because you don't want to ever give too much. Um, and then, has anything made any of the symptoms better or worse? Like, is the eye symptoms better or worse at a certain time of day? Is it better or worse after showering? Different things like that. So, yeah, I think that's a pretty good list of questions to ask. So, based off of the patient's presentation of the fever, the eye discharge, the ear pain, the cheek pain, what kind of conditions do we think this patient might have? What are some things we need to be thinking about?
Possibly something with the tooth. It's
Yeah.
kind of a stretch, but
No, it's definitely could be a possibility. Kids are not the world's best dental patients. We don't know if he's brushing his teeth regularly. Maybe he's eating a handful of Sour Patch Kids before he goes to bed every night. So it could just be like a cavity factory in there, and we would have no idea. So dental issues is definitely something to think about. Any other things we're thinking?
Maybe an ear infection since you said his ear was hurting.
Yeah, definitely. Ear infections are very common in pediatric patients, and especially since he's complaining of ear pain, that's definitely something to think about. Any other conditions we're thinking of? I know someone had said allergies. We were talking about allergies, maybe they're having some sort of allergic response to something. And then the one other thing is since he has this eye nastiness, he's got the discharge and the inflamed eye, maybe he has some sort of conjunctivitis or a pink eye. So I think that's a pretty comprehensive list of differential diagnoses that we can work with. So I found, so they don't really provide any physical exam photos, but I wanted to kind of walk you through what you might find on physical exam for a patient like this. So these are obviously not from this specific case, but this is what you would probably find. So on physical exam, his eye looks like this, and then the right ear, which is the ear that has the pain, it looks like this, and then this is his left ear. So looking at these photos, what kind of diagnoses do we think this child might have?
definitely an ear infection, like Kathy said.
Yeah, definitely an ear infection. This right ear is definitely infected compared to the left ear. And then what about the eye? Do we think he has some sort of eye infection, a pink eye, or conjunctivitis? Yeah, I would say so. So these are both correct. For this specific patient, he has multiple diagnoses. So he has both an ear infection as well as an eye infection. So we're going to break down both of these types of infections um, because they're very common to see in the urgent care. And that way we can just get into a little bit more of the nitty gritty with each of them. So we're going to circle back to this particular patient's case after we've done a little bit for each condition. So We're first going to talk about the eye infection or the conjunctivitis. Conjunctivitis is just inflammation of the conjunctiva, but when you talk about pink eye, that's what it's referring to. It's conjunctivitis. So there's several different types of conjunctivitis that you'll learn about. So there's bacterial, viral, and allergic. The easiest way to kind of keep these separated in your mind is think about the discharge that's associated with each. So, bacterial, you're going to have that goopy, sticky, nasty discharge that we saw in the previous photo. The way that you would describe that would be purulent. For viral and allergic, it's going to be more watery discharge. So, I'm sure sometimes you've had your eye water or something, that it's going to be that consistency. It's not going to be really sticky. There's not going to be any real color to it. It's just going to be kind of watery. So you can look though at these visuals. There's a lot of really good charts and things out there that kind of break down the symptoms you should be looking for the different types. And there's a lot of good visuals out there to help you better identify the type of conjunctivitis you're looking at. So if a patient has a conjunctivitis, they have a pink eye, and that's the only problem that's going on with them, they don't have an infection anywhere else, you would traditionally treat that with some sort of drop or ointment that goes into the eye. So the thinking behind that is because you're directly putting the medication on the area of infection, you're going to have increased amount of drug delivery to that area, and you're going to have enhanced levels of drug action compared to if you take it by mouth. When you take medication by mouth, it gets processed in the liver and other parts of your body. So the amount of drug that you're actually consuming is not the amount that's written on the bottle because it breaks down as it goes through your GI system. So since you can just put an ointment or a drop in your eye, you're going to have a lot more of the drug actually get delivered, which is really nice. The only reason I'm bringing this up is because I have had patients, this is not even like an exaggeration. When I was in the urgent care on one of my rotations, I had a very old male. I don't know, maybe not very old, but he was like in his 60s. He had pink eye and he wanted to take pills. And I had to explain to him that's not really the most appropriate thing. Let's just do eye drops. It's going to heal a lot faster. And he was like, well, I don't have a wife. How do you expect me to put eye drops in? So sometimes you're going to have patients that are going to say things like that. And it's nice to have a little bit of information in your pocket about, well, this is why that's the appropriate treatment to do. So if it's viral or allergic conjunctivitis, the kinds of drops you would use would be like antihistamine drops or decongestant drops that are specifically formulated for the eye. And then for bacterial, you could use antibiotic drops or ointments. But those would be like the kinds of treatments you would do. So does this all make sense, by the way? We're going to move on to the ear infection. Okay. So moving on to ear infections. When you think of ear infections, your traditional ear infection is going to be a middle ear infection, and that's going to be referred to as otitis media. Otitis externa is your outer ear infection, and that's like swimmer's ear. So that's when you have the kids who go swimming all the time and the outside of their ear is really puffed up and it hurts to touch it. That's what your outer ear infection is. But for this this kiddo, he had a middle ear infection. So we're going to talk about that. So like I said, the outer ear is basically everything you can see on the outside, and it's the beginning part of the ear canal. The middle ear has the eardrum, which is called a tympanic membrane, and it has some of these small bones that vibrate in response to sound. So sound's going to travel through your ear canal, it's going to cause your eardrum to vibrate, and it's going to make these bones move. That in turn is going to activate your inner ear, which is full of fluid, and then as this fluid moves in response to the vibration, you're going to have the nerve impulses go to your brain and say, okay, we're listening to a sound. So with the middle ear, this section is basically an air-filled system. So the tympanic membrane's gonna create a barrier between the outside world and then this air-filled cavity. And this air-filled cavity connects to the eustachian tube, which you can see in this photo up here. So the eustachian tube is this tube that connects that air-filled cavity in your ear to basically the back of your nose and your throat. It's like if you could poke a stick up your nose and it would go like till it hits the back of your throat. That's about where it is. So if one part of this system has some sort of event, the rest of the system's going to respond accordingly because it's all made up of the same type of mucosa and it's not that big of a system. So in children, these eustachian tubes are very short and they're almost flat. So with kids, they can get inflammation or fluid that's stuck in one part, and that can cause then you to have that inflammation and infection in that middle ear because it's not going to be able to drain properly. You could have some sort of like pus or fluid that's stuck there and there's nowhere for it to go. That's why ear infections are so common in kids, because just the mechanics of this tube, it really promotes not a lot of movement, and it's really easy for things to just kind of fester in there. But as we get older, the eustachian tubes become longer and they become more angled. So that's why it's not as common for adults to get ear infections, because it promotes that drainage. Does that explanation make sense? Okay. So with kiddos, there's going to be some sort of stoppage of the fluid or just other junk that's in that tube, and the bacteria will be able to grow and, travel back to cause that middle ear infection. I also included 2 photos again of the eardrums. You saw these like not that long ago, but your normal eardrum should be this like very pale color. They describe it as pearly gray in medical textbooks. I don't know who decided that that's pearly gray, but it's just this really pale pink color. You can kind of see the outline of some of the bones up. Like this is one of those small bones. You can also see this little reflex. They call that the light reflex, and that just indicates that um, as you're using the otoscope to look back there, the light's bouncing off of the tympanic membrane properly. You can also see that it's like almost gray pale back here because again, it is that air-filled system. There shouldn't really be anything back there except for empty space. With the infected eardrum though, you see all this white, that's pus. So that's from all that nasty junk that got stuck from the eustachian tube. It's not getting to drain out and it's stuck now behind this eardrum by these small bones. So that's why it's so painful for kids to get ear infections, because there's all this extra pressure in that system that's not normally having it. It can also cause the eardrum to bulge outward. This is called bulging, where basically just all that extra pressure is forcing the eardrum to go in the opposite direction. And sometimes it will become this like red, angry color. So those are the things to look for when you're looking at eardrums to see if they have some sort of infection. So going back to our patient's case, so he has these 2 conditions going on. He has both an ear infection as well as a conjunctivitis. So this specific phenomenon of having these 2 conditions together, it's called otitis conjunctivitis syndrome. So this is when your patient has both of these 2 things going on. Like I explained, about 25% of patients with a conjunctivitis will also have a middle ear infection at the same time, even if they're not complaining of symptoms. That number jumps to 73% when they have that purulent discharge, which is what our patient had, the really gunky, goopy stuff. So it's really important when you have a patient coming in for a pink eye, always check their ears because they actually might have both conditions at the same time. And that would classify it as otitis conjunctivitis. So in a case like this, since you have infection in more than one area, it would be appropriate to use oral antibiotics because you're going to have to kind of target a few different places at once. If it was just the pink eye, you could do the drops. If it was just a middle ear infection, you could also do oral medication as well, because there's no way for the medication to penetrate the tympanic membrane. So you're still going to have to give it by mouth. So since he has both things going on, we don't want to torture the kid. We're just going to give him some liquid amoxicillin, and that'll take care of everything. Any questions on this case?
Is there a specific reason why? Because the pink eye was more on one side than the other, and then the opposite ear was affected. Is there like an explanation for that, or is it just like it just happens?
Sometimes it can just happen like that. Pink eye is one of those things where if you're touching, like bacterial pink eye, you spread through contact. So he probably has, I mean, for some miracle, he's been able to keep it isolated to that one eye. In kids, it's really common to have eye infections in both eyes because kids are always touching everything and they're never washing their hands. And, so it's really easy to spread it that way. But, from some minor miracle, he's been able to keep it just on that one side of his face. For the ear, I'm not exactly sure why that side is bothering him, especially because he has the cheek pain on the opposite side. So I'm not, it's tough to say. I wish they had included some photos because sometimes they'll do photos of what the inside of the patient's ear actually looks like, but they didn't do that in this case. It might be possible that he has an ear infection on both sides, which would make more sense, especially since he has this discomfort on the cheek, because that might be due to the eustachian tube. But it's hard to say, under actual outcomes are like, yeah, we gave him medicine. Great. So it's tough to say. But the one other thing with this otitis conjunctivitis syndrome, it's most commonly associated with a type of bacteria that's called Haemophilus influenza. It's abbreviated H period flu, or like influenza, so H flu. So that way, if you ever hear this again, that's the bacteria that's most commonly associated with it. But there's a lot of different types of bacteria that can cause ear infections and eye infections. It's just for whatever reason, this specific type is known to do this combination. Okay, so we will move on to the next case if nobody else has any questions. Oh.
I did have a question.
Oh,
For
yeah.
the name of for that bacteria that you mentioned, is that just common in like little kids, or is it just common in like the ear and eye infections?
Haemophilus influenza is common with ear and eye infections and upper respiratory infections. There's a lot of different kinds of bacteria, like I said, that could cause both of these conditions. And that's one of the things about medicine that's frustrating. Sometimes you don't necessarily have the tools to isolate the exact bacteria that's causing something, especially when it comes to ear infections, eye infections, and then sometimes like respiratory infections. You have to kind of take your best guess. So it can cause other things though, but as you go through your education, you'll learn that there's certain types of bacteria that like to hang out in certain parts of the body. And this is just one of them that's very common for eyes, ears, nose, and then like a little bit of respiratory stuff. They kind of like separate, which is nice. At least they keep it easy for us. So, okay. Except for like chlamydia and gonorrhea. That's a nightmare. That can go anywhere, but that's a topic for a different day. So we're gonna move on to the second case. So it's case 30. The title is Sore Throat and Headache. So let's watch this.
Hello, we have a 5-year-old young man here with us today who's going to tell us a little bit about his throat. Wyatt, how old are you?
5.
And Wyatt, what's bothering you today?
My throat.
Anything else bothering you?
No. Your head.
Oh,
My head.
your head, yeah. And we heard from Wyatt's mom over here that he had a fever of almost 102 this morning, and he has a sister who happens to have streptococcus pharyngitis. Wyatt, if you would do us a favor, please open your mouth really big. Very good. And we can see here a rather inflamed throat with palatal petechiae, swollen tonsils, a strawberry tongue. Thank you, Wyatt. Good job there. And if you'll just put your head up one more time, and you can't fully perceive this, but their glands are swollen on both sides and a little uncomfortable for him when we were touching them earlier. Wyatt, you did a good job. Thank you very much. You gonna smile for us?
So we have a 5-year-old who's coming in with throat pain. There's also a reported fever. Mom said that he's had a fever Tmax of 102, and he also noted that he had a headache. The sister was diagnosed with strep throat, which is streptococcal pharyngitis. And then on exam, they looked into his throat. They saw there was some inflammation. They saw that there was something called a strawberry tongue. I don't know if you can see it too well in this photo, but if you Google strawberry tongue, it's basically this condition where all the little spots on your tongue become more pronounced. They also said he had palatal petechiae. Petechiae are these little spots that indicate that there was some sort of blood rupture. So you can see them on the back of the throat if there's a lot of coughing or retching. Sometimes people will get petechiae on their face after they've had a wild night out and they've spent all morning throwing up in the toilet because all of the extra force has caused some blood, like capillaries to burst in their face. So that's basically what it is. And then the doctor also commented on the inflamed lymph nodes in the neck. So we can look at vitals and demographics. I also wanted to say, as a provider, the technique he used to interview the patient was great. Sometimes it's tough talking to pediatric patients because some of them will be very nervous and they'll keep looking at mom or dad or the adult that's with them for guidance on what to say or how to act. But I always try to talk to my patients, especially my younger patients, like they're regular human beings, like they're adults using regular language. Don't baby talk them because it's going to build their confidence to talk to medical providers as they get older. Because I'm sure we all have some anxiety even when, we go to the doctors, and it's good to start building those skills when they're younger. So looking at vitals and demographics, wow, they gave us so much information. So we have a temperature of 99.3, so that does not classify as a fever. Fever again is 100.4. No blood pressure, no pulse ox, no height or weight, but his heart rate looks okay and he's breathing in a normal rate as well. So do we want to ask any other questions? Is there anything else we're thinking about?
Well, she said that the kid had a fever before, but he doesn't look to have one now. So, like, when did the fever subside, or if she gave any medication?
Yeah, that's a great question to ask. Especially, if they did give medicine, because depending on the timing before they end up leaving, we might need to give them medicine again, especially if the fever was extremely high right before they came in. What kind of conditions are we worried that this patient might have? What are some of the diagnoses we need to think about?
Maybe he might have the symptoms of like the strep throat, since the sister had it too.
Yeah, he might have strep throat, especially because you're right, sister had it. So it's very common if one child comes down with something, someone else in the house might come down with it too. So definitely. Are there any other conditions we think he could possibly have?
Even just like the flu?
Yeah, he could have the flu, definitely. Yeah, so I think those are two good diagnoses to worry about. When I hear about somebody who's having throat symptoms as well, if I'm not already thinking about flu or strep throat, the two other diagnoses I always like to think about is, do they have a simple upper respiratory infection, which is just like your common cold, or do they have mono? Mono seems a little extreme in this age group, but you can get mono as a very young child because it's not just transmitted through kissing and some of those activities that we all associate it with. There are kids that, because children are monsters, they'll put their mouth over like a water fountain, and then if they have mono, that'll then get in everyone's water. So there's other ways you can get it, or even sharing utensils, sharing food, things like that. So I always like to kind of keep those four diagnoses together when I'm thinking about somebody who has this presentation of symptoms, because it could really be maybe any one of those four. So, as a provider, if we think that a patient has strep throat, which is called strep pharyngitis, we can use a tool to help our decision making to decide if they need to be tested for strep. Because in an urgent care, you're going to be dealing with patients that don't always have insurance. They're not going to want to pay for stuff that they don't need to have. And it's nice to have tools like this because it will help justify your decision making. So the tool we're going to talk about, it is called the CENTOR criteria, CENTOR. So this is a set of criteria that's used to identify the likelihood of a bacterial strep throat infection. The letters can be used to help remember what this criteria stands for. They don't break it down like that in this, but I'll explain. So C stands for can't cough or cough absent, which is right here. E stands for exudate. Those are like the white spots on the back of your throat on your tonsils. That's right here. N stands for nodes, so lymph nodes. That's what anterior cervical LAD, anterior cervical lymphadenopathy. So the lymph nodes in the front of your neck are enlarged. That's what that stands for. T stands for temperature or fever. And then the OR in CENTOR stands for young or old. So if they're younger, it's more likely. If they're over the age of 44 or old, it's less likely. So thinking about the array of symptoms our patient had, what do we think his score would be? He's 5 years old, just for reference.
I think 4.
Yeah, that's perfect. Yeah, I got 4 as well. So he had a fever. He's young. So that's 2 points. He did not have a cough. So that's another point. And his lymph nodes were big when they did the exam. So that's 4 points. So what the heck does this even mean? So when you're evaluating patients, if you can like plug their symptoms into this, and it will help justify your decision making for if they need to get a rapid strep test or not. So since he got a score of 4, he would qualify for a rapid strep test. It would say that it's very strongly encouraged. So we're going to talk about rapid strep tests now. So since we need to do a rapid strep test on this child, we are trying to identify, obviously, if he's having that bacterial strep throat infection. Before I kind of dive into this, does anyone know how strep tests work? If you want to Google it and just give like a 1-sentence summary.
I saw that it's a quick rapid or a quick throat swab.
Yeah. Yeah. Do you know what the throat, like when they're swabbing the throat, do you know, does it say anything about like what they're looking for in like the liquid when they put it in the liquid? It's okay if they don't.
Reading.
No, it's fine. Don't worry. Yeah.
Um,
So, oh,
Sorry. Yeah,
oh,
I was just gonna say, like, would they look for like antigens that like migrate to like a visible line? It's kind of like chromatography. It's kind of like that's how I'm thinking about it when I look at the description.
yeah, definitely. Do you know what the difference is between like an antigen and an antibody? I'm not trying to put you on the spot. Anyone can answer this. Um, So, an antigen basically they're produced quickly when someone has an infection. So, that's to show if someone has dealt with that infection very recently. So, once the infection is gone, usually the antigens are disappear as well. Antibodies is what is produced after you've had the infection for a little bit because that's what ends up recognizing and detecting the infection in the future. So they take longer to form, they're not there as quickly. So with this specific test, you guys definitely hit the main points. The back of the throat is going to be swabbed with a sterile Q-tip, and then they're going to take the mucus that was collected and put it in a tube that has different reagents in it. And the reagents basically um, contain antibodies that are going to detect if that antigen is there. Because remember, this is the antigens made in a really short period of time when someone's sick. So the antibodies are going to bind to those antigens, and then that's what's going to be detected on the stick to show if someone has the infection or not. This is a super common test that's done in an urgent clinic or urgent care, and students get a lot of practice doing this because it's usually something that is in our wheelhouse and it's pretty hard to mess it up. So you'll probably get a lot of practice doing these throat swabs. My biggest piece of advice when you do this, you always need to do 2 Q-tips at the same time. Does anyone have any ideas why?
Because it's harder to go back for a second sample, considering the location of where you're trying to get the sputum sample from.
Definitely. So what would you then do with the second Q-tip?
So the first one's used for testing.
Yeah, the first one's going to be used for this test. What do you think we would do with the second Q-tip? You can phone a friend if you want. It's not a big deal. This is so low pressure. You want me to be your friend? I could be your friend.
Okay.
Yeah. So you definitely hit the point. I don't know if anyone here has had this test done, but it's extremely uncomfortable, and especially doing it on a child. Good luck trying to get back in there to get a second swab. So the reason you do 2 Q-tips at the same time is because once you use the first Q-tip for this test, you can't use it again and you're going to have to throw it away. The second Q-tip is for in case this test is negative, because then you're going to need to send that second Q-tip to the lab to get cultured onto like a petri dish. The cultures are more sensitive and they'll be able to better identify if a patient has a strep throat infection compared to the sensitivity of these rapid strep tests. Because sometimes someone will test negative on this and then they'll send the petri dish to the lab and it will grow out that strep bacteria. So they did have the strep bacteria, just they weren't able to pick it up on this test. So that's why you need to do 2, because if a patient tests negative, you should always be sending a culture just to confirm that either they do have it or they don't. So that's like your confirmatory test. If someone tests positive, obviously you would just treat them and you could throw away the second Q-tip. But it's just better to have it in case instead of having to torture the patient again to get the sample. So good work. So with our patient, they did this rapid strep test and it ended up coming back as a positive test. So the antigens from that bacterial infection in the throat were detected. So that basically means he has strep throat, strep pharyngitis, just like his sister. So for the rest of class, we're just going to talk a little bit more about strep throat. But before we move on, I just want to make sure that this all made sense. Any questions? Cool. Okay, so we're going to just talk about strep throat for the rest of class. So strep throat or strep pharyngitis, it's a bacterial infection in the back of the throat. It is most common in school-age children, but it can occur in younger children, especially if they have contact with older children. So since he's a little young to be in school, most likely what happened is that sister is probably older and picked it up at school and brought it home. You can also get strep throat as an adult. I don't know if anyone has had that experience, but it's miserable. I had strep throat a few summers ago and I thought I was dying. So it's not like this is one of the conditions you grow out of as you get older, unfortunately. So some of the classic symptoms of strep throat is shown in this photo here. So you will have these white spots on the tonsils, which are called exudates. Exudates are very distinct looking. You can see them in this photo right here. Oh, sorry, someone was typing in the chat. What's the difference between tonsillitis and strep? Tonsillitis doesn't necessarily have to be caused by the strep bacteria. Strep throat is caused by a specific type of strep bacteria. There's a whole bunch of different kinds of bacteria, but like strep is a name of a specific family of bacteria. Tonsillitis doesn't necessarily have to be caused by that. And it's just going to it's going to cause that inflammation of the tonsils. It's not going to necessarily cause some of the other complications with strep. Does that make sense? Okay, cool. Sorry, I always forget to look at the chat. My apologies. So we were talking about the exudates. That's one of the very common symptoms with strep. You can see the photo here. It's pretty distinctive. They almost look like spider webs on the tonsils. The throat will also look a little bit more inflamed. It'll look angry. There'll be some redness in the throat. And then you might also have that strawberry tongue, which they talked about in the video, which basically all of the little dots on the tongue will become very pronounced. And it's literally going to look like a strawberry from the store with those very pronounced markings. So, you know, not every patient presents as textbook. Like for instance, our patient, he didn't have these exudates, but that's why you need to use tools like the center criteria and some of your other medical decision-making tools to figure out what's going on and make sure you're doing the appropriate steps and making sure they're diagnosed and treated. I also wanted to show this photo for the viral pharyngitis. You can have inflammation in the throat, which is pharyngitis, and it can be caused by viruses as well. So you're going to have that irritation and inflammation, but it can be hard to tell again because maybe the patient will have the exudates, you know, maybe their tongue is going to make some changes. So it would still be appropriate to do the rapid strep test on these patients and also send the culture because likely the rapid strep test, I mean, it should be negative because it's caused by a virus. So it would still be appropriate to do those steps because for viral pharyngitis, since it's a virus, it's going to clear up on its own. You don't need to prescribe antibiotics. And by doing those tests, you're confirming that it is a virus and you're not going to be contributing to the overprescribing dilemma that we're dealing with now and antibiotic resistance and all that other fun stuff that you hear about on the news. So does anyone know why it's so important to make the diagnosis of strep in a timely manner and make sure we're treating it correctly? Are there any conditions that we're trying to avoid the patient from getting from an untreated strep infection? Feel free to Google that. You can Google like strep throat sequelae or strep throat complications.
If left untreated, or for a long time, it can cause complications like kidney inflammation and rheumatic fever.
Yeah, so rheumatic fever is one of the big things we're trying to prevent by treating strep throat appropriately. Because strep throat on its own sounds pretty harmless. It's just like, okay, it's just this bacteria in the back of your throat. But if you don't catch a strep throat diagnosis and you don't treat it, it can cause rheumatic fever, which is basically this inflammatory condition that's going to affect your heart. It's going to affect your joints. It's going to affect your brain, your skin, your kidneys. It can lead to long-term heart damage that it's basically going to weaken the valves between the chambers of your heart. And some people, can die from the long-term complications of that. So it can really lead to some nasty stuff if it's not treated appropriately. So that's why it's really, everyone wants to do these strep tests because we want to make sure we're catching this. And this isn't, rheumatic fever isn't just something that happens in like a third world country. When I was doing my rotations in New York City, there was a lot of patients that were coming that had rheumatic heart disease, which is when the rheumatic fever is, what happens after the rheumatic fever. The heart is going to have changes to it. Those valves are not going to be working properly. And it's like a lifelong thing they have to deal with, which is scary. Does anyone see any other complications from untreated strep throat infections?
I also found meningitis and pneumonia.
Meningitis and pneumonia. Yeah, I mean, I guess it could lead to that. I guess you could get a strep infection in your lungs. The meningitis is probably more related to maybe the rheumatic fever because it's going to be inflammation of the meninges in your brain. But yeah, I mean, I could see that happening.
I see otitis media as well as glomerulonephritis.
Yeah. So glomerulonephritis, I couldn't pronounce that for the life of me. So you did a good job. So glomerulonephritis, it's basically this inflammation in the kidneys, and it's going to cause issues with how your urine is excreted and some of those, some of like the markers that show your kidney function. So it can definitely cause that. It could lead to ear infections. It could also cause something called scarlet fever, which is basically a skin eruption that's due to a toxin that's released from the strep bacteria. Your skin's just reacting to the toxin and it makes your skin really red. And it can also, scarlet fever can predispose someone to get rheumatic fever. So there's just a whole host of problems that come if we don't catch these infections in time. So to treat strep throat, we're going to need to prescribe antibiotics. If they're young, like this kid, this is why I have such beef with these vitals. We need a weight on this kid because there's no way this 5-year-old is going to be able to swallow pills. So when we give medication that's liquid, especially for kiddos, it needs to be based on their weight. So the most common antibiotic they would give would be amoxicillin. And again, we need to ask, are they allergic to anything? Have they ever had this medication before? Have they had a reaction to it? But if they have had some sort of allergic response to amoxicillin, they can get a medication that's outside of the penicillin family. So the most common medication would then be Zithromax or azithromycin. That would be like the substitute. So that's it for this case. Does anyone have any questions about what we covered?
Just a quick question of like the first case. It just came to my mind right now.
Yeah.
When we look inside, or like when doctors always like look at your ears every time like for a checkup, are what they looking for an ear infection every time, or are they also looking for something else?
Most likely they're looking to see if you do have an ear infection of some sort. because when you look inside the ear canal, you can see the walls of the ear canal and you can see the tympanic membrane. That's all you can really see. You can't see any of the small bones that are behind it unless there's like a hole in your tympanic membrane. And you can see wax. That's pretty much all there is. So they're probably looking to see if you have some sort of ear infection, especially with people who come in complaining of ear pain. If there's possibility that they had trauma to the ear, they might be looking to see if there's a hole in that eardrum. Like Q-tips could cause that, or other, like if they fell and hit their head on something, there could be like a rupture in the tympanic membrane. But that's pretty much all they're looking for. There's not like any other conditions they could really be checking out on the inside of the ear. Yeah. Also, just like a fun note, if you want to do your own strep test at home, they sell like those kits on Amazon. They're not super expensive, but again, you can't prescribe your own medicine. So I don't know how helpful it would be at this point, but just like a fun fact. So when you're older and you can prescribe medicine for yourself, you can just swab yourself and be like, okay, I have strep throat. So, okay. So that's all I have for today. If you have any questions, I will stay on. Otherwise, I hope you have a good rest of your day. And I'll see you guys on Friday.